Welcome everyone to today's presentation on inflammation, based on Chapter 3 of BRS Pathology. In this session, we'll explore the physiological and pathological processes of inflammation, focusing on its types, mechanisms, and clinical relevance. By the end, you'll have a comprehensive understanding of both acute and chronic inflammation. Inflammation is the body's natural response to harmful stimuli such as pathogens, damaged cells, or irritants. It is protective but can become harmful if uncontrolled. Acute inflammation occurs rapidly to address injury or infection, while chronic inflammation is prolonged and may result in tissue damage. The hallmarks of inflammation are redness, swelling, heat, pain, and loss of function. Acute inflammation is the first line of defense against injury or infection. The classic signs, redness, swelling, heat, pain, and loss of function, are due to the body's vascular and cellular changes to address the injury. For instance, redness and heat result from increased blood flow, while swelling arises from fluid leakage into tissues. Pain is mediated by chemical signals that activate nerve endings. Vascular changes are critical in acute inflammation. First, arteriolar vasodilation increases blood flow, which explains the redness and warmth. Then, increased vascular permeability allows immune cells and plasma proteins to move into tissues, causing swelling. This leakage, or exudation, delivers essential components for defense and repair. The accompanying diagram illustrates these processes. Note the dilated blood vessels, fluid leakage, and movement of immune cells. Leukocyte recruitment is a key cellular event in acute inflammation. Neutrophils are the first responders, followed by monocytes, which later differentiate into macrophages. The process of leukocyte extravasation involves several steps. First, tethering and rolling slow the leukocytes. Then adhesion firmly anchors them to the vessel wall. Then transmigration occurs, which allows them to move through the vessel. And finally, chemotaxis guides them to the injury site using chemical gradients. This illustration helps visualize these steps for better understanding. Notice, tethering and rolling followed by adhesion and then the transmigration and finally chemotaxis. Inflammation is orchestrated by chemical mediators. Vasoactive amines, like histamine, cause vasodilation and permeability. Plasma proteins, such as the complement system, help fight pathogens, while the coagulation and kinin systems contribute to clot formation and pain. Eicosanoids, like prostaglandins, amplify inflammation by causing fever and pain. These mediators are the primary drivers of inflammatory symptoms and are potential targets for therapy. Acute inflammation can have several outcomes. Resolution: the injury heals completely without permanent damage. Suppuration: pus formation occurs when neutrophils and dead cells accumulate, as seen in abscesses. Fibrosis: scar formation happens when tissue repair includes collagen deposition. Chronic inflammation: if acute inflammation is unresolved, it may progress to a chronic state. Each of these outcomes depends on the nature and severity of the initial injury. Chronic inflammation lasts for weeks or months and involves mononuclear cells like macrophages, lymphocytes, and plasma cells rather than neutrophils. Causes include persistent infections, e.g., tuberculosis, autoimmune diseases, e.g., rheumatoid arthritis, and prolonged exposure to irritants, e.g., smoking. Unlike acute inflammation, chronic inflammation often leads to tissue destruction, fibrosis, and functional impairment. Macrophages play a central role in chronic inflammation by secreting pro-inflammatory cytokines like TNF and IL-1, recruiting other immune cells. They also clean up debris and release growth factors to repair tissue. In granulomatous inflammation, macrophages cluster together to form granulomas. This is a protective mechanism against pathogens that are difficult to eradicate, like Mycobacterium tuberculosis. It shows the dynamics of granuloma formation and pathology in tuberculosis. Mycobacterium tuberculosis elicits a local inflammatory infiltrate which may give rise to I. Protective immunity, 2. Balanced inflammation by control of tuberculosis growth with little tissue damage, or 3. Endobronchial transmission following granuloma necrosis. Inflammation has systemic effects beyond the localized response. Fever is mediated by pyrogens like IL-1 and TNF acting on the hypothalamus. Leukocytosis involves an increase in white blood cells, especially neutrophils in bacterial infections. The acute phase response includes elevated levels of markers like CRP and fibrinogen, which aid in inflammation assessment. These effects reflect the body's effort to fight injury or infection on a broader scale. Chronic inflammation underlies many diseases, such as rheumatoid arthritis, inflammatory bowel disease, and vasculitis. Management includes anti-inflammatory drugs like NSAIDs and corticosteroids, as well as biologics targeting specific mediators, such as TNF inhibitors in autoimmune diseases. Modern therapeutic approaches aim to balance inflammation to minimize damage while promoting healing. Let's recap the key points. Acute inflammation is a protective, short-term response, while chronic inflammation is prolonged and can cause tissue damage. The hallmarks of acute inflammation are driven by vascular and cellular changes, while chronic inflammation involves macrophages and lymphocytes. Inflammation is a double-edged sword. It's vital for healing but can contribute to chronic diseases if uncontrolled. This presentation is based on Chapter 3 of BRS Pathology and other standard pathology texts. Accurate knowledge of inflammatory processes is fundamental to understanding various diseases and their management. Subscribe for more educational videos.